Hello. Thank you guys for being here. I am Dr. Janelle Bolton, one of the maternal fetal medicine docs here at Northwestern, and it's my pleasure to introduce our speaker for today, Dr. Lynn Yee, a dear friend and colleague for over a decade now. She is the Thomas J. Watkins Memorial Professor of Obstetrics and Gynecology and a tenured associate professor in the Division of Maternal Fetal Medicine, Department of Obstetrics and Gynecology. She completed her residency in obstetrics and gynecology at the University of California, San Francisco, and fellowship in maternal fetal medicine here at Northwestern. She has been a part of our division since then. Dr. Yee leads a large multidisciplinary NIH-funded research program that is dedicated to addressing issues of health equity, health disparities, and health services in obstetrics. In addition to being the Northwestern PI for the multiple research networks, including the Maternal Fetal Medicine Units Network, she has particular interest in understanding social determinants of obstetric health and in developing interventions which may improve health for communities and individuals in greatest need. Today, she will speak about her work on patient navigation in the postpartum setting.
Thank you, Dr. Bolin. I'm really delighted to be here and honored to have been asked to present about my work. I'm particularly excited because really presenting this work is sort of a decade's worth of projects or research over a course of interest in patient navigation and pregnancy and postpartum health that I will try to cram into 45 or 50 minutes and leave time for questions. I have no conflicts of interest. I do have mostly federal funding with some foundation funding, no industry funding. I will start by just saying a few comments about language and positionality. As an obstetrician gynecologist, I care for patients who both identify as women and don't identify as women. We will try to use the word pregnant people and individuals where applicable, but sometimes people, when they do identify as women in the literature, we will use that language in accordance with how they're reported in the papers. And then just as a reflection on my own role as a researcher, whenever I talk about my work on patient navigation or social determinants of obstetric health, I think it's important to take a moment and pause and think about my own positionality. I've listed some characteristics of my own identity there, and I always think it's critical as public health researchers to take a moment to acknowledge how that may affect our interpretation of our own research work. My objectives today are threefold. One is to identify how patient navigation can promote access, quality, and equity in healthcare. Two is to understand the preliminary and emerging data on patient navigation in postpartum health. And then three, maybe most importantly, is understanding how to initiate patient navigation programming through the lens of implementation science. Let's start with understanding the rationale. Why should we consider interventions to promote maternal health and postpartum health? I know I'm a little bit preaching to the choir here. You all are here at an IFAM talk, so you've heard the fact that maternal morbidity and mortality in the United States are profoundly above what they should be and above what most other countries are, and that not only are mothers dying, but they are dying inequitably. We know that in the United States, there's a massive mortality gap for U.S. moms, and that non-Hispanic Black women have rates of maternal death that exceed that of most of the global South. We know that the disparity between Black and white women is not entirely explained by socioeconomic status, although there's clearly intersectionality between different social determinants of health, but that education is insufficient to overcome the massive barriers that have been incurred by things like institutional racism. We'll speak about that more in a moment. We also know that maternal mortality is not just during pregnancy. For the non-OBGYNs in the audience, you may think, well, maternal death is something that occurs in pregnancy or in the labor and delivery setting. Actually, as this nice figure from Commonwealth Fund shows, a large amount, 65% of maternal mortality actually occurs in the postpartum period. We're not going to get into the definitions here of pregnancy-associated or pregnancy-related death, but I think it's really important to acknowledge that delivery is not the endpoint, that maternal risks go on long term. And then one thing that we don't note here in this figure is that those risks that occur during pregnancy tell a picture about one's future health over the long-term period. They inform the kind of care, preventive care and otherwise, that we need to provide for people who have been birthing individuals long past the time that their postpartum period ends. So despite knowing that maternal mortality is increasing, it is unacceptable, and it is highly inequitable, postpartum care, which seems like the prime opportunity to prevent morbidity, is very much lacking in the United States. It is lacking in quantity, quality, and equity. We know that there is suboptimal receipt of postpartum care, and in fact, in some parts of the country, only 40 to 60% of people have an appointment. We know that there's inadequate transition of primary care, and if you look at vast amounts of data on this, including some from our own institution, you'll see that a small minority of people transition to postpartum to primary care. And you might think, well, is that because they're healthy? These are largely healthy young women and that they may not have many comorbidities. Well, if you break it down and look at people who have comorbidities, we will see that that transition to primary care is no better. There are major missed opportunities for health promotion. And then it goes without saying that there are substantial disparities in how postpartum care is delivered, the quality of such care, and then the transition efforts afterwards, in part because of the way our payer system in the United States works. What are the goals of postpartum care? Some of the things I've summarized here are really important for understanding the intervention that we've developed. They include to optimize recovery, provide effective family planning methods when desired, to identify and care for mood disorders, support lactation, initiate preventive care, promote long-term cardiovascular and metabolic health, and probably most importantly, because it enables all of the rest of those things on this list, is to support social needs. Yet we know there are many barriers to optimal postpartum care. My team has studied some of this, and you'll see in some of the slides, some of the pictures of my team members who've carried out pivotal work related to navigation in our prelim data. And we've studied the multi-level barriers using the social ecological model as our theoretical framework to understand barriers to receiving postpartum care in our kind of academic urban setting. We know that transportation, childcare, language, and work obstacles are prevalent. Inadequate health literacy is a barrier not only to receiving care, but then to executing the recommendations from that care. The fragmented healthcare system is a major problem. I may deliver a patient right across the street at beautiful Prentice and then need to send her to one of our neighborhood FQHCs, but not have a healthcare system that can easily communicate information to them. Limited access to primary care and inability of some patients with public payers to access long-term primary care clinicians can be a real challenge. Poor communication of pregnancy-related events. One interesting thing we've studied is that our primary care partners in this Navigating New Motherhood project that I'll tell you about sometimes don't even know that a patient had hypertension or had a gestational diabetes diagnosis. And that lack of communication of events means a missed opportunity for prevention. And then scheduling and insurance burdens. All of these can prohibit patients from optimizing their health in the postpartum period. We know that many of these are ultimately considered social determinants of health. This here is, of course, a wheel that all of you have seen, and it's in EPIC, or a version of it is in EPIC, from Healthy People 2030, where we understand that social determinants of health are really at the root of problems that we encounter in receiving optimal care in any healthcare context. But here we're going to focus specifically on pregnancy and the postpartum period. One thing I think is important to acknowledge is that the disparities that we see in race and ethnicity, socioeconomic status, and other characteristics are not due to, obviously, race and ethnicity themselves, but are due to the underlying social determinants that lead there to be these incredibly disparate outcomes between those who are more privileged and those who are very underserved, some of which you can see here. Things like stress, knowledge, language, self-efficacy, access, stigma, bias, racism, and so on. And targeting these aspects, these social determinants of health, have been sort of at the foundation of the work that my team does. So let's move from understanding the rationale for an intervention to discussing the intervention itself. Let me tell you a little bit about patient navigation. So patient navigation is a patient-centered intervention that uses trained personnel to facilitate complete and timely access to health services. It is a fairly simple intervention, and one of my longtime mentors would say, Dr. Melissa Simon, who's done much work on patient navigation, would say it's actually a Band-Aid for a broken healthcare system. And indeed, that is true, and I hope you'll see how if we had a more functional healthcare system, you may not even need patient navigators. Yet here we are, we do. So the origins of navigation are really in the 1990s in Harlem. In Harlem in the 90s, Dr. Harold Freeman noted that Black women were getting diagnosed with breast cancer at much more advanced stages and having higher rates of mortality as a result. And he implemented this patient navigation program in order to improve morbidity or reduce morbidity and mortality in this population. And it was highly successful. From then, it became a standard of care in the oncology field. And now all comprehensive cancer centers, NCCN designated centers, have patient navigators. It is funded by Medicare and Medicaid for cancer centers. It is routine, yet it is not routine really outside of the oncology setting. You'll see some literature in HIV, some literature in diabetes, various pockets of chronic disease areas where navigation has become a part of care. But really, it's a rather new principle, particularly for obstetrics, a rather new principle outside of cancer. Harold Freeman wrote about these principles of patient navigation, which I won't go through, but leave them here for you to glimpse at for a moment. It is a patient-centric healthcare delivery model in the top. It also needs to have a clear scope of practice. As I'll talk about in a moment, navigators are very different from case managers, social workers, community health workers. And while there's a nice Venn diagram that you can imagine that overlaps their skills and functions, they are not exactly the same. They are healthcare system embedded individuals. Also, navigation needs to have a variation in the work it does based on the level of skill needed. For example, an oncology nurse navigator for someone undergoing chemotherapy might be vastly different from the type of navigator that we use in our postpartum program using essentially lay navigators. In addition, there has to be an endpoint. Navigation doesn't go on forever. It doesn't do everything for a patient that they might need for their entire life, and it has to be cost effective. So see, these are some of the primary principles that Harold Freeman proposed and are still relevant today. So my team considered this literature from oncology and thought about how can we adapt this to the obstetric context. And we came up with these 5 goals of patient navigation relevant to our healthcare setting. Number 1, to identify patient-level barriers to healthcare access. Number 2, improve timeliness of care. Postpartum care has things that should be done in a particular time period, as does antenatal care, which I'll speak about at the end. Provide health education. As you can imagine, the postpartum period is a time of rapid learning and growth for not only the individual, but her family as well. And that health education may be essential to promoting long-term health. Number 4, offer social support. As you can also imagine, the postpartum period may be lonely for many individuals, and that's associated with mood disorders and suboptimal health for other reasons. So social support can be key to remaining engaged in the healthcare system and keep maintaining health. And then finally, facilitating shared decision-making. We hypothesize that addressing social determinants of health lays the groundwork for improving patient self-efficacy and long-term engagement in the healthcare system. In other words, following these 5 principles and addressing the social needs that prevent you from having optimal health eventually means that you may become an independent user of the healthcare system without the need for a patient navigator. We also hypothesize that navigation promotes health equity and this navigation does this by 3 reasons. 1 is having this patient-centered mindset. 2 is having a systems level expertise and tools. This is where navigators differ quite a bit from community health workers or case managers because they have an in-depth knowledge of how our healthcare system works, while also having the 3rd pillar, which is access to an understanding of community resources and understanding where to refer patients, how to get them into community resources that may be uniquely able to address their social needs. And by doing all of these 3 things together, we hope to improve health equity. In other words, by building bridges between the patient, the system, and the community, we think we can move the needle on long-term health outcomes. So who are patient navigators? There are a range of backgrounds. And if you look at the literature on navigation, interestingly, you see everything from highly trained nurses and nurse practitioners, all the way to peer navigators who may have relatively little or informal training. And all are very much appropriate depending on the context. We don't know that because of this variability of training, there's an importance of developing a core training curriculum and competencies. My team, led by, in this paper, Hannah Green, who just graduated, worked on developing core elements for obstetrical navigator professional development and published a manuscript where we propose how to train an obstetric patient navigator. We think this is important because standardizing what navigators do is essential to having a standardized, scalable intervention, as you'll see in a moment. But at the same time, we also acknowledge our training is designed for lay navigators, and there are many other systems out there where that may not be quite appropriate. So I'm going to tell you first about Navigating New Motherhood 1 to set the stage for Navigating New Motherhood 2, which we've just finished. So Navigating New Motherhood 1 was generously funded by the Friends of Princess Foundation back when I was finishing fellowship. And this project took place between 2015-16. Our goal was to develop and implement a multifaceted, patient-centered, short-term postpartum patient navigation program for a low-income community. This took place here at Prentice, and we performed a 1-year program of short-term navigation, meaning up to 12 weeks postpartum, for people who had Medicaid as their payer for their pregnancy and postpartum period. We recruited all patients who were eligible in our Prentice Ambulatory Care Clinic over a 1-year period and compared them to people who would have been eligible but were receiving care in the prior year. We found that those who were exposed to the navigation intervention, even though it was short, had improved postpartum visit attendance, a 3.5-fold improvement, had improved uptake of World Health Organization Tier 1 or 2 contraception, in other words, the highest quality contraceptive methods, had better uptake of depression screening and vaccinations as well. All of this was very promising, but we thought, well, before we go on to do a large randomized trial, we need to do some evaluations. And I'll condense, oh, and one more thing before I get back there. These are some of our improvements in our outcomes. One other thing I want to point out here, see if I can use this, no, it works, the laser pointer, is GTT completion. Although not statistically significant because of our small sample size, I think it's pretty interesting to note that there was a nearly 3-fold increase in glucose tolerance test completion for patients who had gestational diabetes in the period who were exposed to navigation compared to those who were not. So not only do we have some improvements in uptake of general postpartum care, but for those who need specialized care, like those who had gestational diabetes, we know that there may be hints of signals of improvement for them as well. But we thought we need to do some evaluation of our program before we go on. This slide really condenses several papers worth of work where we did a couple interesting things. One is we did an in-depth communication analysis of patient and navigator interactions. In other words, we took every single text message and email thread between navigators and their patients and analyzed all of them for themes of discussion points and tried to understand what's the volume of work that a navigator is doing, what themes and frequency of communication is associated with better uptake of the intervention and thereby improving uptake of postpartum care. We tried to understand how relational aspects of their communication may have enhanced the quality of the intervention and whether talking about educational topics versus appointment logistic related topics was more likely to result in sustained engagement in care. And that was fascinating and really led to us to be able to refine our intervention for the future. Then we also did a parallel mixed methods evaluation of patient, clinician, and administrator key partners. We looked at things like what the navigators did in clinic and whether what the administrators and clinicians saw was aligned with what the navigators said they did. We looked at what the patients thought based on some standardized scales of navigation uptake. We also looked at what clinicians thought of how the navigators integrated into clinic. Was this acceptable, feasible? Did it slow them down or speed them up? And we found a lot of fascinating data that I won't share with you today for the sake of time, but that really set the stage for our lessons learned and next steps. So what did we learn from Navigating New Motherhood 1? This was a multifaceted, patient-centered navigation program, and it was associated with improved postpartum retention and other health outcomes compared to a historic cohort. We learned that training and integration of the navigator into the healthcare team was essential. You could not just drop a navigator in and hope all went well, but they really needed to be a part of the team, embedded in their everyday work in order to be successful. We also learned that the quality of patient navigator communication was key. This is a relational intervention, and you cannot have dot phrases or standardized text to make that relational part work. We also knew that we needed patient feedback into program development, and that was essential to refining it. We also knew, and any clinician here will understand this, that we needed to function without a need for physician involvement. We could not depend on our busy OBGYN residents and fellows in order to have them say, oh, this patient would be good for a navigator, or can my navigator do this for the patients? We needed to have the navigators function independently and be able to seamlessly work behind the scenes and not disrupt flow or require the physicians to remember that they exist. And then we also needed, clearly, since this was the focus of the study, individualized attention to health and social needs. This was not a one-size-fits-all template. Some people needed hefty intervention with multiple touch points, which we studied, and other people needed very light touches, and that was able to be successful. So this showed us that there were multiple areas for expansion, and a major area of expansion was including a focus on primary care, which was part of our Navigating New Motherhood 2 intervention. So in Navigating New Motherhood 2, we were fortunate to be funded by the NICHD. This was a randomized trial of 405 pregnant or postpartum people with publicly funded prenatal care who were randomized to receive navigation versus usual care. They were those who were randomized to receive navigation received intensive individualized navigation for up to 1 year. So it was intensive through 12 weeks and then tapered through 1 year postpartum, although as you'll see in some of our data, that tapering sometimes was still fairly intensive. These are the aims of our grants, some of which the analyses are somewhat still ongoing. But number one was to evaluate whether the intervention, Navigating New Motherhood 2, compared to usual care, improves clinical outcomes at 4 to 12 weeks postpartum and 1 year postpartum. Number two is to evaluate whether the intervention compared to usual care improved patient-reported outcomes. Those data we're still analyzing, so I won't be sharing with you today. And number three was to analyze clinician experiences with the intervention. And you'll see here is our conceptual framework for the intervention. Take a moment to just memorize those colors, and you'll see in a moment why they're important. But ultimately, we really believe that addressing social determinants of health improves access and entry to care, which promotes self-efficacy and health literacy, ultimately leading to our goal of sustained long-term engagement and improved postpartum and interconceptional health. This was a single center, non-masked randomized trial. We enrolled people starting right before the pandemic through June of 2023, and our last participant exited in August of 2024, since we followed them for 13 months. They were randomized to navigation versus usual care in a 1-to-1 ratio, and the enrollment occurred in the late part of pregnancy, so between 30 weeks and postpartum discharge. And if somebody was eligible but delivered before 30 weeks and we were going to miss them in clinic, we tried to approach them in the hospital as well. They had 3 study visits and enrollment 4 to 12 weeks and 1 year postpartum, where we collected a variety of patient-reported and medical record data. People who were eligible were those who had a pregnancy that achieved at least 20 weeks of gestation and were aged 16 or greater. They had to have publicly funded antenatal care. For the vast majority of our patients, this was Medicaid, not Medicare. They must be able to speak and read English or Spanish and be an established patient here without intent to deliver elsewhere. These were our guiding principles to the intervention. Number 1, first and foremost, was addressing social determinants of health. We knew that there are postpartum specific barriers that prevent optimization of health. So we wanted to focus on barrier ascertainment and reduction with this intervention. Number 2 was long-term success. We are not doing this program just to say we're going to help you for a year and then see it. The point here was to promote long-term self-efficacy and grow an individual's health literacy such that they improve their health literacy and self-efficacy so they do not need a navigator in order to ultimately leave the program feeling able to handle their healthcare on their own. And then finally, there was a clear scope of practice. We knew that we needed measurable outcomes and a clear endpoint when navigation ended, as well as boundaries between what does a navigator do and what does a social worker do, for example, or what does a navigator do and what does a therapist do. All of these things were important parts of our program development. The intervention itself looks a little bit like this. We knew that the foundation of it, as I've mentioned, was social needs assessment and support, but also critically, it was healthcare appointment coordination. Our navigators have special access to Epic that allows them to schedule with patients right there in the room and they're in the hospital so that patients do not have to wait on that very annoying phone tree and then ultimately give up and not make an appointment at all. We also trained our navigators to work on insurance assistance. Now, interestingly, during the time of our study, Illinois Medicaid extension to 1 year postpartum took place, and so that really reduced the amounts of insurance work we had to do. But still, some of our patients lost insurance, and our navigators helped with that. Health education about postpartum care, and particularly the transition to primary care, was essential. And then finally, advocacy and support for shared decision-making. We can probably all think of times when you left a room wondering, did my patient understand that complex thing we just talked about? Well, our navigators were there in the room. So they were able to say to a patient, did you understand what Dr. Yee just said about your options for this or that? And the patient, if she said no, the navigators were empowering the patients to ask more questions and would literally go down the hall and say to the doctor, I need you to come back to the room. She didn't really understand her contraception choices and feels a little bit stuck. And therefore, we are learning to advocate for ourselves in this process. We had standardized transition and communication documents, which are both on paper for people who desired it and in Epic, especially important for our primary care transition process. And our navigators were highly trained, bilingual lay navigators who were embedded into the clinical team. In fact, I will tell you some of our residents, especially those who came in when the project had already started, really didn't know that they were like research staff. They just thought, well, some of my patients get a navigator. Isn't that great? They were so highly embedded. These were our tasks. I'm not going to walk you through these, but what I do want to call your attention to is the colors in the dots in the table. So every activity that the navigators did was mapped onto our theoretical framework. Is this a self-efficacy promoting activity? Is this a social determinants of health promoting activity? And we made sure that we understood when and how each of these activities would be executed so that ultimately they could be executed with high fidelity to the intervention in order to ensure long-term sustainability and success. A lot of what we did were the first 2 bullets, barrier assessments and rapport building, but then all of the other things on there were done at repeated time points, appointment reminders, connection to resources, coordinating handoffs. These were not one-time events. These were things that take place over a sustained period of time and eventually wind up being completed by the time the year is done. So what were the primary outcomes of our study? We created a composite of what we called receiving optimal postpartum care. This was based on what ACOG says qualifies as having received optimal postpartum care. It consists of retention and postpartum care, meaning coming to your appointments, receiving all indicated anticipatory guidance or counseling, receiving desired family planning method, having postpartum depression screening and care if indicated, initiating and maintaining breastfeeding, and then finally, receipt of all indicated vaccinations. And if I had to do this study again, that is the one I wish I had not included. You'll see why in a moment. But I think that this is important because ideally, in an optimal health scenario, we would achieve all 6 of these. We also created a couple secondary outcomes. Of course, we looked at each of the components of the primary individually. We also looked at a postpartum care score. And this was a novel concept that my colleague Joe Feinglass and I developed in order to sort of grade the quality of postpartum care. It's not really all or nothing. Even though that last outcome I just showed you, ultimately it was a binary yes or no, we knew that there's a spectrum of postpartum care quality, and that's what the score is supposed to indicate. And then we looked at 1-year health services outcomes, whether you continued use of your desired family planning method, whether you attended a primary care visit, maintained breastfeeding, and had diabetes testing among those with GDM. And then PROs, which we won't talk about today. Our sample size was estimated to be 400 people. And pay attention to this number here. We expected the rate of the primary outcome in those who did not have navigation to be 50%. In other words, I estimated that 50% of those in the usual care group would have optimal postpartum care, and that we would have a 20% absolute increase in the primary outcome with navigation. I'm next going to show you some data that are not published. I'm working on the paper slowly but surely, but we did present it as an oral plenary at the Society for Maternal Fetal Medicine meeting a couple months ago, where this was the objective of just the primary aim, which was to evaluate whether it improves postpartum healthcare quality among people with low income. We screened 1,519 individuals and approached 598, of whom the vast majority agreed to participate. 405 were randomized, and 203 were to navigation, 202 to usual care. We had 2 navigators performing this work over the sort of 4-year period. We found that the average age of the population was fairly young, about 27. The majority of our participants identified as non-Hispanic Black or Hispanic. Most, despite our availability of the intervention, spoke English. We had a very underserved population. Only 15% had a college degree. Nearly half had a household income less than $25,000 per year. Keep in mind that about 50% of these people already have children, so these are households not just of 2 people. And that nearly 40% were uninsured prior to pregnancy. This is also a population with a significant amount of morbidity. As expected, about half were nulliparous. Only about 10 to 12% were initiated prenatal care beyond 20 weeks. But we had a high BMI, and we had a high proportion of patients with chronic hypertension, pre-gestational diabetes, or pre-existing mental health conditions prior to pregnancy. So high amounts of both social and clinical morbidity for our navigators to work with. So I told you before that we expected that 50% of our patients would achieve optimal postpartum care in the usual care group. It turns out that we were really, really wrong, and that our postpartum care composite was only achieved at 8.6 of the overall percent of the overall population. This was one of the most depressing things that I saw when we started looking at our data, but it gets better. Let me show you a little bit about how this breaks down. So we ultimately showed that in the usual care group, 7.9% of people achieved all 6 outcomes. Remember that composite, to get a yes for this outcome was 6 out of 6 points on that optimal postpartum care composite, compared to 9.4% of patients in the navigated group. While that seems fairly abysmal, when you look at some of the data about the individual components, I think we can see where the benefits of navigation lie. So first of all, let's look at completion of a comprehensive postpartum care visit. Nearly 100% of people in the navigated group returned for postpartum care by 12 weeks postpartum, which is impressive, and that is rarely seen in other interventions. Now, interestingly, 80% in the usual care group is much higher than literature when we were writing the grant, but nonetheless, that nearly 100% in the navigated group was really quite a desirable outcome to us. Second, we saw that 65% versus 51% received all indicated anticipatory guidance, meaning the presence of the navigator improved the quality and quantity of counseling that the clinicians are providing to the patients. This is not counseling provided by the navigators. This is counseling provided by the clinicians that we are assessing through their medical records and improved with navigation. Next, we saw that 86% versus 72% of individuals who received navigation had screening for postpartum depression to care, and critically, not just screening, but linkage to long-term care. There were no differences in receiving desired family planning method, initiating and maintaining breastfeeding, and then take a look at vaccinations. This is where we really fell down. And I think what's interesting about vaccination is that so much of the decision making about vaccinations has occurred before the navigators have met the patients. And so maybe we couldn't move the needle on this outcome at the time of the intervention's initiation. We also know that our world has become much more anti-vaccine than it was, when we wrote this grant, initially planned it. So I think there are some challenges to work on there. I mentioned earlier the unique postpartum care score concept. So this is an exciting concept here, and we found that our postpartum care score with navigation patients was 72% compared to 64% among those who were in the control group, meaning 72% was the proportion of postpartum care components achieved in the navigation group, showing that even though we're looking at this outcome as a binary all or nothing, that actually we're doing pretty well with the provision of postpartum care. We just aren't at 100%. And then let's look at the components of anticipatory guidance. These are the topics that our professional society says we should be talking to postpartum people about. I won't walk you through each of them individually, but take a look at the numbers in the navigated group. You'll see that the vast majority of patients received counseling on almost all of the topics that they were supposed to be counseled on, and that this was better in the patients who received, much better in the patients who received navigation versus usual care. Now, this is at the 4 to 12 week time period. We do have data on our 1-year counseling by primary care physicians, trying to understand whether our colleagues in general internal medicine, both here and at our FQHC partners, did a better job of counseling. And we'll be analyzing those data with the help of GIM faculty Natalie Cameron soon. Then, interestingly, and perhaps here's where the money's at for navigation, let's look at our 1-year outcomes. Among those patients who received navigation, 65% were receiving or continued use of their desired family planning method at the time of their 1-year visit, which was between 11 and 13 months. 57% versus 30% had attended a primary care visit. 26% no difference in breastfeeding. And then super cool is diabetes screening among individuals with GDM was nearly 100%. And this is not just your GTT, but we actually grouped for this composite, either having had your 4 to 12 week glucose tolerance test, which is standard of care, gold standard, but also if you'd gotten an A1C or any other screening at any point later in the year if you missed that early opportunity. So much better there in the 1-year outcomes. So what did we find? Number one, sadly, even in our outstanding healthcare system, achieving optimal postpartum care is rare. And the composite measure did not improve with navigation. But patient navigation improves multiple components of postpartum care and, importantly, the transition to primary care. And that's how we set up our birthing people for long-term success. We also know that navigation reduces gaps in care availability, accessibility, acceptability, and quality, but that we may need to begin earlier. This focus on social needs was great. It really helped us optimize care for many, but not all patients in the study. But there are a lot of things, like I told you about vaccination, maybe breastfeeding too, where intervening at the end of pregnancy perhaps is not the right time to really have make a difference on decisions that might have been solidified at an earlier time point. So, knowing all we know about the trial, at least that was aim 1 of the trial, we've been thinking concurrently with executing the trial about how to implement this for sustainability. How can we make sure that our intervention is set up for long-term success so that one day I can go to our hospital leaders and say, look, I think we have enough evidence to make this a hospital expense, to have navigators as a part of our team and not a research expense. Let me walk you through some of the work we've done to try and sell that story and help show you that navigation can be done sustainably through a lens of implementation science. So first, implementation phase 1. We were really interested in seeking clinician partner input. And with the help of Abby Filico and Rachel Ruderman, Rachel's a former resident, Abby's a current resident in OBGYN, we looked at a couple things. We looked at obstetric provider perspectives on navigation for low-income patients. So this was done really early in the study to try to understand what our clinician partners thought about the implementation of navigation, how it affected their workflow, and in particular, areas they thought navigators could be most helpful. We also looked at providers' perspectives on barriers and facilitators to care. There's actually a lot of literature out there on patient barriers to care, but not what providers think and what providers see as their own barriers to providing optimal care. And we looked at primary care clinicians. We interviewed physicians here in GIM as well as at some of our FQHC partners in the community to understand what they thought about using patient navigators to bridge the gap between the academic healthcare system or our big fancy downtown hospital and the long-term sources of care where most of our patients go. These helped us really understand how to refine the intervention in order to make it most acceptable to the populations of interest. And importantly, we did this all through a really rigorous theoretical framework. We, again, used my favorite model, the social ecological framework, to understand the barriers to care throughout the healthcare system in the postpartum context and define them as environmental, access-related barriers, institutional, interpersonal, and individual, and really mapped out what clinicians thought about these barriers. And this is the obstetric version of the barriers. This is what we looked at for primary care versions. So this figure's a little bit sharper imaging. Sorry about the last one. This one looked at the barriers to primary care receipts in this postpartum population. And putting these two models together helped us understand how navigators can target multi-level barriers in the most efficient and effective way. We also talked to clinicians about who they thought could benefit from navigation. One thing that I think it's important to recognize is that there will never be a healthcare system in the US that can sustain an intensive patient navigator for every single patient. We know that's not feasible in the way our healthcare system works. And so we thought quite a bit about who needs a navigator the most, who needs them the least, or how can you have some navigation be very high touch, high intensity for those who are in that dark green bubble, low social support, low health literacy, complex medical course, lots of psychosocial complexity, versus low touch, light touch interventions for those who have the opposite of that in the light green circle on the left. And using that intervention or using that framework, we tried to think about how our intervention could be refined such that not everybody who was in Navigating New Motherhood got the same intervention. Next, in our implementation phase 2, with Hannah Green's help, we defined, as I told you earlier, what I considered sort of a baseline standard for how to train a patient navigator. And this has been actually one of the most fun aspects of this work, is that now we were able to go out there and say, look, some aspects of navigation work, some don't. But if you want to do it in your own healthcare system, we think there need to be some standardized common grounds for what you consider adequate training. We need to look at the principles of navigation. They need to have knowledge of the clinical context. They need to understand principles of health promotion and cultural sensitivity. They need to really importantly have an understanding of care coordination and community resources. And then finally, they need to understand the EMR. That's critical to being embedded in the healthcare system and is one way they differentiate, as I mentioned earlier, from community health workers. So we defined this training curriculum, and then we started measuring how we were doing with it. So in our implementation phase 3, we use a consolidated framework for implementation research, one of the sort of more well-known implementation science frameworks, to understand how we were doing at implementing the program. We knew that navigation offered a novel opportunity to streamline care, but because it was not yet routine, there were probably some implementation bumps that needed to be figured out before this moved to a non-research setting. So our objective was to identify barriers and facilitators to their integration in the healthcare system. And the way we did this was by analyzing all the data from their first year of navigation using the CFIR constructs in both a qualitative and quantitative strategy, which I'll just show you a little bit of the data. For example, our navigators kept intensive logs for their first year. We actually ended up backing off on these logs because it was way too much work, but it helped us understand the low workload and the need of navigation. What I really like about this simple figure is that you can see over the 13 months of the intervention, although there was a lull in the amount of work that needed to be done per patient in the middle of their postpartum year, it was never zero, or it was rarely zero. And there's still an average, let's say 5 to 10 tasks per patient that needed to be done in each of those middle months. I think this really changes the paradigm of postpartum health. We often think of postpartum health as ending at about 12 weeks postpartum, and we say, goodbye, go get primary care. We hope you're well. We'll see you at your next pregnancy. But look how much needs to be done in this time period. We also then looked at interviews with the navigators, the notes that they took, their logs about communications with clinicians, and then analyzed it using this CFIR construct. Anyone who's seen the CFIR knows that this picture here looks like how the framework works, where you have the outer setting or the context in which the intervention takes place, your inner setting, your characteristics of the individual, the process, meaning what did we actually do to make this intervention work, and then the characteristics of the intervention. And in the boxes and circles there, you can see the language we use and how we map that on to the CFIR constructs to say what was working, why was navigation successful? Well, there's a high patient need. We learned how to communicate with other settings. We used the EMR, but what made it less, what were the challenges, the pain points? There were varying levels of patient engagement. Sometimes our navigators had frustrations over patients they knew who needed their assistance, but were unable or unwilling to engage. But what were some successes on the individual level? We knew that navigator self-efficacy and their own ability to learn and continue their education was key. Their personal growth commitment was an essential part of the intervention itself, not just a part of hiring, but really a part of the ongoing intervention success. And then there's a number of other characteristics you can see there, like high adaptability. As I said multiple times, this is not a one-size-fits-all intervention. And although we had a protocol, and although we had that nicely color-coded figure showing us how everything maps onto the framework, we know that some people need some things, some people need others, and the adaptability is what makes this intervention ultimately successful. But as you can see on the bottom part of the gray box, ultimately the complexity of the intervention also challenges its sustainability. And this is where it really now the rubber hits the road in thinking about long-term post-research, is we need to think about how to reduce the complexity while sustaining some of the other things in this figure. That led us to implementation phase 4. So, I thought about all my colleagues who work in like genomic sciences and do really awesome biological sciences, and they make heat maps of genetic things. And I thought, I can do that too. So we took all of the data from the navigators' first year of logs. We looked at every single interaction that the navigators had with our participants and made a qualitative heat map where we looked at the type of work that they were doing at every month. You can see months on the x-axis at the bottom, and in the y-axis are the categories of things the navigators did. Darker red indicates more intensity, white indicates white gray is less intensity. And you can see that there's a great intensity of work that needs to be done in the very beginning of the postpartum year. But then look at kind of how it shifts. There's more parenting tasks in the middle of the year, like helping, remind them about breastfeeding or newborn documentation. Legal aid was a big one. There's more long-term health and wellness. And then there's relationship building throughout. Peaks at the beginning and end, but still throughout the middle. And one thing I really love about this qualitative heat map is we took sort of demonstrated strategies of science to say, how do we quantify the intensity of work, and applied it to implementation science and put this together to say, what does this tell us about how to make a business case for navigators? I now have data where I can say that we do need navigators to not just cut off at 14 weeks or 6 months or some other arbitrary time point, but to say that there's a varying amount of need that happens throughout the year, but never really goes down to nothing. Using those data, Hannah created a nice figure that's published in the Journal of Women's Health that looks at how the navigators interact with the different care teams and the different types of activities that go on throughout the year. You can see that at the top is this concept that we called setting up for success, building patient activation, promoting self-efficacy, developing knowledge of the health system, and so on. And then below that, and I should say setting up for success happens throughout the year. Whereas things like connection to primary care and specialists may have a later start point and an earlier end point. Accomplishing some of those earlier postpartum goals is like perhaps a earlier end point. And then the recovery point really ends much earlier, and then it becomes more long-term health promotion. All of this requires integration of multiple teams, which you can see on the bottom, and the navigator serves as a key bridge between those different teams. Our next phase of the implementation projects was what we called our Implementation Advisory Board. Our Implementation Advisory Board was a group of clinicians and administrators, clinicians of all types, nurses, social workers, patient service representatives, clinic managers, residents and faculty, who gathered on a quarterly basis and then less often as the project became more integrated, to give us feedback on how we were doing. And this wasn't just a typical stakeholder advisory board or community advisory board where we took that feedback in and wrote about it. We actually changed the intervention midway at multiple time points in order to improve how we worked in the clinical setting. So Hannah's work involved analyzing the documentation from those IAB meetings, where we surveyed them and took notes at every meeting, and then used the EPIS model, exploration, preparation, implementation, and sustainment, to understand what our IAB was telling us and how that could be a model for future implementation advisory boards. So that was an exciting publication last year in Implementation Science Communications. And then Hannah's last project with our student Maya Dater, who is about to be a third year, was implementation phase 5, identifying health system gaps through navigation. So here we interviewed the navigators serially. So we had 2 navigators most of the time, a third one covering for a short maternity leave. And Hannah interviewed them every 3 months throughout the entire project, resulting in what was it, nearly 20 separate long-term interviews that allowed the navigators to tell their stories, to tell us the things they were doing on a day-to-day basis that weren't reflected in just the quantitative data. And then we have a publication that we are now revising for Women's Health Reports that's looking at how the overall health systems challenges, postpartum care challenges, and gaps in transition to primary care intersect with each other from the viewpoint of the navigator, this really unique perspective that hasn't been documented in the literature before. Then finally, Maya recently presented at the Society for Maternal Fetal Medicine 2 interesting papers about patient perceptions of our program. Again, key to our implementation phase. So first, she presented patient perceptions of the program, where we looked at qualitative patient interviews. Patients were randomized to be invited to do an extra interview or not, as well as patient surveys about their experiences with their navigator. And she presented in oral format an abstract, which you can see in the QR code, about their actual need for services. So what services did patients use their navigators for from their own viewpoints, and how satisfied were they with the services they received, which is, tell you the punchline, they were incredibly satisfied. So this leads me just to our final thoughts, and we'll leave time for questions. I think it's important to acknowledge that there are still a lot of gaps in understanding how to frame navigation as a long-term intervention to help this obstetric population. We need to understand, for example, whether to target specific outcomes or an overall obstetric or postpartum health composite like we did here. We also really need to invest in health economics evaluations in obstetrics. And this is one of my next goals, is to try and identify a collaborator who can help me understand the cost effectiveness of our intervention here, even knowing that our primary outcome wasn't significant. Seeing that how we move the needle on multiple other outcomes, I think demonstrates that there is a lot of potential cost benefit to this, but we need to prove it. We also know that postpartum cardiovascular health promotion is a really hard thing to embark upon. Getting postpartum people who are sleepless, potentially depressed, potentially little social support in an environment which may have higher likelihood of intimate partner violence, perhaps with little maternity leave, cannot easily invest in exercise and healthy nutrition. Yet doing so has so many long-term health benefits, and this window of opportunity is one that we really think navigators can intervene upon. But how early is too early to start? Should your long-term health promotion start at 4 weeks postpartum, or should we wait till a year? Or have we lost our window by then? I think it's still an outstanding question. We also need to understand some differences between having a health behavior focus, like the individual behavior, like exercise, smoking cessation, getting your contraceptive method, versus the health services focus. And as I think you've seen here, this project really intersects the two, in that we are working on individual health behaviors, but through a health services lens. But sometimes interventions really shouldn't do both, and I think there's more to understand there. We also know that there's probably heterogeneity of treatment effects. Dr. Feinglass and I have been thinking a lot about parity and trying to understand whether there are differences in parity, in the outcomes by parity. And I can tell you our prelim analyses of these data show there's not, that we didn't find that first-time moms versus moms with other children had any difference in the primary outcomes. But I think there's probably more to learn there. We need to know more about timing, dose, and scalability, and that's what I've been showing you, particularly in those implementation phases 3 through 5, is trying to really understand the dose of navigation that is the minimum necessary in order to be scalable. We need to do antenatal navigation. As I've told you earlier, we need to start early. And then finally, we need to tailor it for new populations. It's not, as I've said multiple times, one size fits all. And that leads us to our next study. So my team has been fortunate to have a new R01 from the NIMHD, which, as long as it still exists, is funding us to do partnering with antenatal navigators to transform health in pregnancy. And this is an exciting opportunity to take what we learned from Navigating New Motherhood 2 and back it up. Now we're going to be recruiting people as early as their first prenatal visit, but definitely before 20 weeks, randomizing them to intensive antenatal navigator versus not, focusing on first-time moms, and seeing whether we can not just improve health services, which was the focus on Navigating New Motherhood, but whether we can actually reduce maternal morbidity, including some major metrics like preterm birth and severe maternal morbidity. So I hope in a few years I can come back and tell you guys that we now have the complete package. We know that if you start early and go through a year, that maybe we can, really change the needle in obstetric morbidity and mortality. In summary, I want to just summarize that promoting the health of pregnant people requires attention to social determinants of health. This may seem obvious to this audience, and you all are here, and I appreciate that, but it's not obvious to everybody. And I think we need to really get that it's not just about developing the new progesterone, developing the fancy remote monitor, developing the new technology, but it's actually about human-centered interventions and having a patient-centered strategy to optimize health during and after pregnancy. And in particular, navigation may be especially needed for those with greater social or medical risk. And this is where, as a health system, we can learn how to triage who needs this precious resource the most. Navigation may reduce gaps in care availability, accessibility, acceptability, and quality, and we need implementation science with a focus on equity components in order to ensure long-term sustainability. I have a lot of people to thank. You can see here our Navigating New Motherhood 1 and 2 teams and our implementation board, as well as our team for the new grant path, my funders, and current research lab members in our MFM team who all work really hard to make sure that obstetric research at Northwestern is moving forward despite the world events. I really appreciate everything everyone on this slide has done to move the needle on women's health.